From the previous video, we discussed coronary angiogram and the roles and responsibilities of nurses in the lab. In this video, we're going to focus more on the indications or the reasons why you bring a patient for a percutaneous coronary intervention, PCI, or what we commonly call coronary angioplasty. But before that, I think it is just right for me to discuss first the risk of us having coronary heart diseases or coronary artery diseases. Because most of us have a fatalistic view of life and we think we are invincible. That's why we don't often think of the risk of us having a disease, especially heart diseases, which I think for me are preventable. We can avoid heart attacks. So what are the risk factors of putting a person in danger of having a heart problem, a heart disease, to suffer angina, or to experience a heart attack? There are actually two types of risk factors. You've got the modifiable and the non-modifiable ones. For the non-modifiable risk factor, we can start with the person's genetic makeup. You see, there are some families who are more prone to have heart attacks or angina more than others. That means there's a certain gene in their system that predisposes them to have these conditions. And having said that, I think, based from what I know, there are no tests that will conclusively predict if a person is at risk of having a heart attack. Some families have a genetic predisposition of elevated cholesterol levels in their system. This is what we call a familial hypercholesterolemia. And I am actually scared because our family has it. And my recent blood work showed that I've got a borderline cholesterol level. So I really need to change my diet, because even though I've got a genetic predisposition, we can manage our cholesterol by changing our lifestyle, changing up my diet. So anyway, there's another genetic condition, what we call homocystinuria. And this is elevated levels of amino acids in our system. And these amino acids can eventually damage the artery walls, and this can lead up to atherosclerosis, which is a buildup of fats, cholesterol, and other substances in the artery walls. When it comes to age and sex, males generally have a higher risk than females, and us males tend to manifest earlier than them. However, when a woman reaches a menopausal stage, that means low estrogen levels, they tend to have a slight increase in their risk to have heart problems. But when we both reach, male and female both reach the age of 65, the risk becomes equal. It is also important to note that family history is relevant if the first degree male relative, that means your father or your brother, has had an angina before the age of 55. And on the other hand, if the mother or sister, first degree female relative, has had angina or a heart attack before the age of 65. Another non-modifiable risk factor is the ethnic background of a person. They said that African, Caribbean, and South Asian are at risk of having heart diseases. It is unclear, the reason is unclear, but this could be because of the blood pressure, their diet, or inherited tendencies. Now we're going to focus on the modifiable risk factors. So these are the things that you can control. And number one on our list is smoking. Smoking, like what they said, is dangerous to your health. It's been emphasized over and over in any adverts, but people tend to be stubborn and they still smoke. And in fact, cardiologists are not advising anyone to smoke because it doesn't even give you any benefit. It can actually lead you to have lung cancer, stroke, and even coronary artery diseases, coronary heart diseases. So you should stop smoking. It instantly gives you a benefit if you stop smoking. And the one thing that's also interesting to know is that passive smoking, even if you are not a smoker, you have a chance of having a coronary artery disease. So a passive smoke can give you 25% risk of having a heart problem. The second modifiable risk factor would be hypertension, uncontrolled hypertension. And as what they say, Hypertension is a silent killer. It can lead to fatalistic conditions such as stroke. In fact, it is the number one risk factor for stroke. And if you are somebody who's having high blood pressure, you should have your GP check you, and you should monitor your blood pressure frequently. And now we're going to focus on cholesterol. Most of us view high cholesterol as bad for us, but we actually need cholesterol in our body. It is actually the balance between the good and the bad cholesterol that we have to look into. Cholesterol is a type of waxy fat substance found in the cells of our body, and it is carried around in our bloodstream called lipoproteins. And there are actually two types. We've got the low density lipoprotein, which is considered as the bad cholesterol, and the HDL, or the high density lipoprotein, which is considered as the good cholesterol. The difference between the two is that the LDL tends to stick more onto arterial walls and build up compared to the HDL. And in order to increase the chance of us having a higher HDL is to eat cholesterol lowering foods such as nuts, high fibered foods such as oats, fruits and vegetables, and also oily fish. So these are the things that you can do to increase your HDL levels. Increasing levels of obesity is associated with increased levels of heart diseases, especially if it is coupled with the secondary risk factors such as diabetes, hypertension, or high cholesterol. In order to measure if we are obese, we need to look into our body mass index, and our goal should be less than 25. And another tool that we use is to measure the waist to height ratio. So we measure our waist circumference over our height, and having a 0.5 or less than 0.5 measurement indicates a lower risk. As a rule of thumb, a waist circumference of more than 40 inches for men and 35 inches for women indicates an increased risk of a heart disease. Next is the lack of exercise or our inactivity. So we all know the benefits of exercise. So the more we regularly become active or do exercises, we become more fit. That means we prevent ourselves from having illnesses that includes heart diseases and stroke. For one thing, it helps control our blood sugar, it prevents us from having diabetes. It reduces the level of cholesterol and also makes us leaner, not overweight or obese. When it comes to our diet, it is recommended that fat consumption should be less than 30% of our total calorific intake, and sodium should be restricted to a safe level, so less salt. And we should have at least 5 portions of fruit and vegetable every day, and at least eating oily fish 3 times a week. And high trans fat food should be kept to a minimum. Drinking a little amount of alcohol is surprisingly beneficial to lower the risk of coronary heart disease. But of course, if you drink too much, let's say 6 units every 6 hours a day, that increases your risk. And this can be seen in the J-shaped curve phenomenon, wherein it shows the risk of death from coronary heart disease measured against the number of alcohol drank each day. And this chart shows that for those people who haven't drunk alcohol, the risk of death is standard. However, if they drink moderately, the risk drops, but it slowly increases as you drink more alcohol. So what this means is that we should drink moderately. But to be totally honest, I think we should just stop drinking, or just drink occasionally if need be. We don't need to drink alcohol each day. But anyway, other modifiable risk factors would be stress or negative emotion. I am affected by stress and negative emotion almost every day of my life. I am affected by this physically, emotionally, spiritually, mentally. So it is best to stay away from stress and make sure that you have a positive outlook in life. Because it seems like a negative emotion or stress can increase the risk of you of having a heart disease. This is hard to quantify, but recent study shows that a negative emotion like anger can increase your chance of having a heart problem. And next would be inflammation. Much research needs to be done regarding the relationship between an inflammation in our body and a heart disease. But as we all know, logically speaking, if there's inflammation in your system, there's an increased chance that you are predisposed to develop atherosclerosis. Yeah, and then last one would be having diabetes mellitus. This means that there's an increased level of glucose or sugar in your system. So this is due to insulin resistance, meaning to say your insulin is not accepted by the cells in your body, so you can use it properly, hence increasing the level of glucose in your system. Or there's a less production of insulin in your pancreas. So there's less insulin, there's no proper metabolism of your glucose in your system. And as we all know, if there's increased sugar in your system, there's a chance that it will damage your arteries and it will lead to atherosclerosis, arteriosclerosis, and other vascular and coronary problems. There are four main ways in order for a coronary heart disease to manifest itself. First is chest pain, sometimes we call this angina. Second is heart attack or a myocardial infarction. Third is a heart failure. And lastly, the fourth one is arrhythmia, wherein there is irregularity in the heart's rhythm. It is impossible to predict which of the symptoms comes first for a person with a coronary heart disease, but usually the underlying cause of these manifestations is arteriosclerosis. However, you have to watch out for the following symptoms if you suspect that the person is having a heart disease or if you are having a heart disease. Number one is chest pain. If you are experiencing like a crushing, stabbing, or a severe central chest pain that radiates to your neck and goes down to your left arm, that is indicative of a cardiac pain. If it is accompanied by like nausea, clamminess, or sweating, or like you feel like you're fainting, that could mean that you are having a heart attack. So you will be needing emergency care or immediate attention. However, if you are having a severe chest pain that lasts only for 2 to 3 minutes upon exercise or exertion, or like let's say you are lifting something or you're running or you're exercising, that means that you are having angina if it is relieved by rest and triggered by exertion. The second symptom that you have to watch out for is palpitations. The sensation of having like a fast heartbeat when you drink coffee or when you are stressed is normal. However, if it is continuous and it is accompanied by shortness of breath, that could mean that you're having an arrhythmia. And also if there's like less perfusion of blood on the part of your heart that causes conduction, that could lead to arrhythmia as well. Third symptom is shortness of breath. And the last one is swelling of the lower extremities, especially your ankles. So these two symptoms might indicate that you are having a heart failure. So these symptoms are very important to take note, but not all the time that shortness of breath or chest pain is caused by heart disease. There are other conditions that might lead you to have a chest pain. That's why if you're the doctor, you need to do a differential diagnosis. Conditions that might cause chest pain could be indigestion or a chest infection like pneumonia, pleurisy, or you may be having a chest wall musculoskeletal pain or shingles, or you may be having like pulmonary embolism. What else? You may be having aortic disease, or let's say, or any type of pulmonary problem. So these things, the doctor need to eliminate these conditions in order to conclude if it is like a heart condition. Now, when you are already in the hospital and let's say you are having a chest pain, the doctor will immediately like work on an ACS diagnosis or acute coronary syndrome diagnosis. But the doctor needs to do like further tests in order to check if this is a heart attack or not. So initial management would be to give the patient, of course, pain relief, opiates, give oxygen to the patient because there's poor perfusion of oxygen in the heart. So oxygen, opiates, antiemetics, to prevent patient from like vomiting. Of course, we need to give antiplatelets to open up the heart. This is a blood thinner like aspirin. And we have to do a 12-lead ECG to check for if there's any like ST elevation or depression or T-wave inversion or peak T-wave on the ECGs. We have to do like blood tests to check for biochemical markers, cardiac markers like troponin, and also we need to do a chest x-ray. So once the doctor has seen this, like check for heart murmurs, scan the heart, he will further diagnose this patient because there could be possible 3 scenarios. The patient could have like unstable angina, could be like NSTEMI or non-ST segment elevation myocardial infarction, or the one that needs PCI, the ST segment elevation myocardial infarction. So what are the differences between these three? For patients experiencing unstable angina, there could be temporary ECG changes like temporary ST elevation, but there's no changes on the cardiac enzyme, so possibly no damage on the heart muscle because the troponin levels is normal, but the patient is experiencing chest pain. For NSTEMI, on the other hand, the non-ST segment elevation MI, in this condition, there may be temporary ECG changes like ST depression or T-wave changes because the coronary flow is partially blocked. So there's ischemia, and it is expected that there's part of the heart that is damaged, so troponin levels may be elevated. And lastly, we've got the STEMI, the ST segment elevation MI, wherein in this condition, the entire coronary artery is blocked. So a whole thickness of the heart muscle is damaged. So troponin levels are elevated. And in this condition, we need clot busting treatment. We need to treat this condition, so either thrombolysis or PCI or percutaneous coronary intervention, or what we said commonly, a coronary angioplasty. Now, what's the importance of differentiating the 3 ACS conditions that I mentioned earlier? So 3 different conditions, 3 different ways of treating patient. So for the first 2, unstable angina and the NSTEMI, both of these conditions may need further investigations like cardiac MRI, echo, or need a stress test, or other procedure, possibly more blood tests. So both of these can be a planned procedure in the lab. It could be scheduled the next day for like a coronary angiogram, just to take pictures and see if there's need to do a treatment like a PCI. And then if it's like a STEMI and there's a clear indication that it's a STEMI, definitely the patient needs to go into the lab. And there are 2 ways of opening up a blocked artery. And as I mentioned, first one is thrombolytics, like the use of streptokinase. And it's given by a drip. But there's a time limit of giving this one. It should be given within 12 hours from the onset of like chest pain. But we have to take note that patients given with streptokinase or having thrombolytics are at risk for bleeding. Now, on the other hand, we've got the PCI, or what we commonly call primary angioplasty. So here we put balloons and stent to open up the blocked artery. But it is best to do this 4 hours from the onset of the heart attack, because the earlier we do the PCI or the treatment, the better it is to save the surrounding tissues of the heart. So yeah, so there's like golden period that we have to do the PCI. So for a patient going into the lab, this is the things that we do. So for instance, I'm on my on-call shift and we receive like a primary angioplasty coming into the hospital. So when the patient's there, patient's being assessed, history is being taken, and then once that we establish that the patient has STEMI, so the patient will need to be loaded with antiplatelets. Normally, we give aspirin, ticagrelor, clopidogrel, or prasugrel. And then patient needs to be consented, patient needs to have a line, there should be a confirmed STEMI, it will be the ECG, patient needs to be connected to a cardiac monitor or a defibrillator, and then we check for the patient's allergies. So patient needs to have like a drip running. I think it is also important for me to mention here that a new onset of a left bundle branch block is considered equivalent to a STEMI according to European guidelines. But I read somewhere on the internet, some references say that a new LBBB is a sign of a chronic cardiomyopathy than ischemia. So normally when we encounter that in the hospital, I usually ask a doctor after they assess, after they've discussed it with the supervising consultant, if the patient needs to go into the lab or not. So anyway, when a patient is already inside the lab, we try our best to make the patient comfortable and stable. And then we do coronary angiogram. So you may watch my video about coronary angiogram, how it is done, because basically it's just the same when we start PCI or a primary angioplasty procedure inside the cath lab. So once we've taken pictures, we saw the culprit artery, let's say it's the left anterior descending, we prepare the PCI kit. But initially, the doctor will change the catheter into a guide catheter, into a larger, with a larger lumen size, because we will be putting, wires and balloons and stent inside that. So the PCI kit consists of an endoflator. We have the O-ring, we've got the, extra heparin, extra nitrates. We prepare the 50-50 solution of hepsaline and the contrast to use to inflate the balloon or the stent. So that's the PCI kit. So for the catheters, to enlighten those who are interested to know, for the left system, we normally use the EBU 3.5, and for the right, the JR4 guide. So I can do more specific a video regarding PCIs probably on the next video, but it's just for you to know what are the things that we do inside the lab when there is primary angioplasty. So when we do primary angioplasty, let's say the doctor has changed the guide catheter already, the doctor will then use the coronary wire initially to poke, the blockage on the artery. And then once the doctor has placed the wire as a guide, they would bring in the balloon to advance up to the blockage and then inflate it so that the atheromia can be squished onto the arterial walls and there will be good blood flow on the coronary arteries. And then the next step, to make things simple, is the doctor would put in a stent. A stent is like a cylindrical stainless steel mesh wire that they would advance onto the narrowed area of the coronary artery, and they would inflate this one so that it would fully open the artery so that blood flow will be better. And then once they deflate, this mesh wire will stay in place to prevent re-narrowing of the artery. And then in order to fully optimize this stent, they would use another balloon to inflate this particular area on the artery. And that's how PCI works. It's better than thrombolytics because thrombolytics is associated with other risks, like what I said earlier in this video, bleeding. That's why PCI is considered a gold standard for patients with STEMI or a blocked artery coronary. So aside from STEMI or a new onset of LBBB, patients may need also angioplasty if they've got a worsening heart condition or chest pain, despite changing their lifestyle or having medications. But not everyone needs angioplasty. Once a patient has had like an angiogram and they saw that there's multiple lesions on the artery, or let's say the left anterior descending that supplies the large portion of the heart is too narrowed, if the patient has diabetes with like 3 vessel disease, and or let's say if the heart muscle is really weak, these patients are not suitable for a PCI anymore. So they would discuss this one with the surgeons to have like a coronary artery bypass graft. So that's it. I hope you like this video. I have tried to discuss the risk factors for coronary heart diseases, and how that will lead to acute coronary syndrome. And from acute coronary syndrome, we've discussed 3 scenarios that could lead to a patient going into a percutaneous coronary intervention. And I hope on the next video I can further discuss things that we do for a PCI and other stuff like intravascular ultrasound or pressure wire studies. Mind you, I'm still learning about all this stuff. I've been a cath lab nurse for 2 years, but I know I still got a lot of things to learn. So if you're watching this video and you're like an expert on this field, try to write something down on the comment section. So this is a community wherein we try to learn from each other, and I try my best to share what I know and what I see, what I experience, so that others can be inspired, probably inspired, and be, learn more for our patients, so that we could be better for our patients. So thank you very much for watching, and I hope to see you next time.